welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Thank you for the introduction. As mentioned, my name is Jaszcz, the current PGY2 emergency medicine resident at Detroit Receiving Hospital at the Detroit Medical Center. We'll be talking about the ANNEXA-I trial that has been highly anticipated. I have no particular financial conflicts of interest to disclose. However, we will be discussing off-label use of some medications today. And there is a poll everywhere that I've created just to get some audience participation. So the first question is, what products do you utilize for the reversal of factor Xa inhibitors at your specific institution? The options are Andexanet, 4-factor prothrombin complex concentrate, 3-factor prothrombin complex concentrate, activated factor product, some of our other factor products, so our factor 7, our factor 8, fresh frozen plasma, or no treatment. So as the poll is coming in, it looks like our most popular product is 4-factor prothrombin complex concentrate, and then followed by Andexanet, which, just for context, at my institution, we also use 4-factor prothrombin complex concentrate. So before we delve into the trial itself, I think it's important to look back in time of some different data and then when these different products were approved. So one of our first PCC products was approved in 2000 with our 3-factor PCC, our oral factor Xa inhibitors, our rivaroxaban, apixaban, as well as edoxaban was approved in the early 2010s, so 2011 to 2015. We have approval of our 4-factor PCC also in the early 2010s, lastly with our approval of Andexanet in 2018. So prior to Andexanet, there was a period of time where there was no on-label FDA indication or FDA-approved product for reversal of our oral factor Xa inhibitors. So the two products we'll be talking about today mostly will be our 4-factor PCC, our 4-factor prothrombin complex concentrate, and then, of course, Andexanet. 4-factor PCC, just as a reminder, contains factors 2, 7, 9, 10, as well as protein C and S. And this is an off-label indication, and the mechanism involves replacing our clotting factors to try to allow these patients to clot and stop their bleeding. Andexanet is an activated factor, which is an FDA-labeled indication and helps try to sequester the drug and reduce anticoagulation that way. 4-factor PCC does have multiple dosing strategies, whether it's fixed or weight-based, and that's in all the different types of bleeds. And then Andexanet has 2 different dosing strategies, a low dose and a high dose, which is given as a bolus, followed by a 2-hour infusion in both of those. Onset of both is fairly rapid, but the half-life of 4-factor PCC is noted to be longer. So we've talked about the different approval times. Let's look at some of the different data that has been gone over the years. So as I said, there was a period of time where we didn't have Andexanet as a product. So what did we use then? There was initially a study in 2011 looking at the reversal of rivaroxaban and dabigatran by a prothrombin complex concentrate product. And this was completed outside of the United States, so a period of time where the United States didn't have a 4-factor PCC approved, but in Europe they had one. So this was a randomized, double-blinded, placebo-controlled trial, really a proof of concept trial to see if patients who receive rivaroxaban, we'll focus on the rivaroxaban piece of this. So these were healthy volunteers. These patients were not bleeding. They were given a super therapeutic dose of rivaroxaban, so not a dose we typically use, 20 milligrams twice a day, and they were allowed to get to steady state. And then patients either received placebo or our PCC product. And what they found is the prothrombin time as well as the endogenous thrombin potential were able to return back to baseline after receiving the PCC product. And this seems to be statistically significantly different between our two groups. So proof of concept, it seems that our 4-factor PCC product does work in this specific indication. Next, moving on to our first ANNEXA trial, so our ANNEXA-A and ANNEXA-R trials. So this is a similar idea. This is some phase 2 data, randomized double-blind placebo-controlled trials looking at healthy adults receiving either apixaban or rivaroxaban, and that they were reversed with Andexanet. they were given a bolus and an infusion or just a bolus. So they were trying to see that the drug works and then trying to figure out a dosing strategy. Because the bolus and the infusion is what is prescribed now, that's the data I have presented here. So first, they tried to see if anti-factor Xa activity was reduced after giving Andexanet, and lo and behold, it was. They also wanted to see if the endogenous prothrombin potential returned back to baseline. And again, in both of our different drugs, it was able to return back to baseline. So thus far, we have some surrogate outcomes looking at bleeding and seeing that both of our products seem to work with those surrogate outcomes. But what about actual clinical outcomes? So that brings us to the ANNEXA-4 trial. So there were multiple different iterations of this trial. The one with a good chunk of the data was published in 2019 by Connolly and colleagues. And this was a multi-center prospective open label single group study. So remember, no comparator group here. This was looking specifically at adults with acute major bleeding. So that could be a major bleed or an intracranial hemorrhage. And they looked at adults who received apixaban, rivaroxaban, edoxaban, or enoxaparin within the prior 18 hours. So they looked at a composite outcome looking again at anti-factor Xa activity. And as we can see, both apixaban and rivaroxaban, after given a dose of Andexanet, were able to decrease the anti-factor Xa activity. So this was a composite outcome of the activity as well as hemostatic efficacy. So they looked specifically at patients with excellent or good hemostatic efficacy. And what they found is that Andexanet had 82% of patients had excellent or good hemostasis after receiving the dose. Again, not compared to a comparator group, but it seems once again that Andexanet does work. However, at the time, many hospitals are also using our 4-factor PCC product, as we saw earlier in the poll, for many reasons, a large chunk of it being cost, however. So how do we compare the two, as this phase 3b4 trial only looked at Andexanet by itself? So there have been many different real-world comparisons, the biggest one being most recently studied in 2023, published by Jaszcz and colleagues. And this was looking at, it was a retrospective observational cohort study trying to compare patients who received Andexanet versus those that received a 4-factor PCC, with patients with factor Xa inhibitor-related major bleeding in US-based hospitals. And so they looked specifically at adults with a diagnosis code of bleeding due to extrinsic anticoagulation, and they had record of taking either apixaban or rivaroxaban. They had received reversal with either of our two agents in the hospital, and then had a documented disposition. So this was done in a large number of patients, over 4,000 patients, and what they found, they looked specifically at in-hospital mortality. So on our y-axis, you can see the percentage of in-hospital mortality, and then you can see the different groups subdivided from overall ICH and GI bleeds. So it seems that there is a statistically significant difference here in rates of mortality in hospital between our Andexanet patients and our patients that did receive 4-factor PCC. However, the patients that received 4-factor PCC, when looking at baseline characteristics, they had a higher rate of hematoma volumes as well as lower GCS scores as compared to our patients with Andexanet. They also had lower rates of neurosurgical interventions as compared to Andexanet. So are we really comparing apples to apples here? Was one group sicker than the other? And once again, this is retrospective, and they didn't include any sort of inkling about safety events that were reported. So this brings us to our trial that we'll talk about, so our ANNEXA-I trial. This was most recently published in the May edition of the New England Journal of Medicine, and this was titled Andexanet for Factor Xa Inhibitor Associated Acute Intracerebral Hemorrhage. So going through our study overview, it was funded by Portola, which was initially owned, or who initially owned Andexanet and then switched to its new owner, Alexion AstraZeneca. The null hypothesis for this trial is that there would be no difference in efficacy and safety outcomes between the two groups, and those two groups were Andexanet and usual care. We'll delve into what usual care means as we go through. This was a prospective open-label randomized controlled trial, similar to many other stroke-related trials. The objective was to, again, assess the safety and efficacy of Andexanet as compared with usual care, specifically in our patients with intracerebral hemorrhage. This was done between June 2019 and to May 2023. Some inclusion criteria. So patients had to have an intracerebral hemorrhage. They had to be on an oral factor Xa inhibitor, and the last dose had to be within 15 hours of randomization. They had to present within 6 hours of symptom onset, have a specific ICH volume between 0.5 to 60 mLs, and then have an NIHSS score of less than 35. So anyone unfamiliar with the NIHSS score, lower numbers indicate more mild strokes, and higher numbers up to 42 indicate more severe strokes. Our trial intervention, again, was Andexanet, either at high or low dose, as indicated, versus usual care, which was up to the local protocol. So this could have been, some places if they used placebo, it would have been placebo. Otherwise, it would have been whichever formulary PCC product that the hospital had on hand. The point was that the comparator group was not receiving Andexanet. Our endpoints, so you had primary, secondary, as well as safety endpoints. So the primary endpoint was looking at hemostatic efficacy at 12 hours. And this was defined as hematoma expansion with a volume less than 35% change at 12 hours. Patients had no more than an NIHSS increase of 7 within those 12 hours, and then also no receipt of rescue therapy within 3 to 12 hours. So this was based on a prior study with warfarin and profactor thrombin complex concentrate, as well as some guidelines and definitions from the International Society of Thrombosis and Hemostasis. Now, the society guidelines do recommend assessing these at a later time point, so 24 to 48 hours. However, of note, these were assessed in this study at 12 hours. There were many secondary outcomes that were proposed for this study. Percent change in active anti-factor Xa activity at 2 hours, something that was looked at prior with the ANNEXA-I as well as ANNEXA-IV studies. The effect of Andexanet versus usual care on thrombin generation, again, something that was looked at before, but not in comparison to 4-factor PCC. The relationship between anti-factor Xa activity and hemostatic efficacy, neurological function, immunogenicity of the study drug, Andexanet, health-related quality of life, the incidence of invasive intracranial procedures after randomization, as this could have an effect on the primary outcome, and then the incidence of rehospitalization at 30 days. As for safety, thrombotic events and death at 30 days were reported. Statistical analyses have 90% power. 900 patients were needed to detect a 10-point difference in hemostatic efficacy with an alpha of 5%. Interim analysis was to occur at 450 patients, so halfway through the study, and then even though this was an open label design, the endpoint adjudication committee was blinded to the different group assignments, which is something similar we've seen in some, again, prior stroke trials. Looking at the results, so first going through the background characteristics, overall it does seem that patients were well balanced between the two groups. Your average patient in the study was older, 70 to 80-year-old patient. They were male, they were taking apixaban for atrial fibrillation, and they were presenting with non-traumatic intracerebral hemorrhage. And most patients were reversed with low-dose Andexanet or PCC. And the median dose PCC that the study had reported was about 3,000 units if the patient was to receive a PCC product. So the primary outcome, looking at their hemostatic efficacy, there was a statistically significant difference between Andexanet and usual care. So you can see that 67% of patients had hemostatic efficacy in the Andexanet group compared with 53.1, and this had a p-value of 0.003. And you'll see some different groups evaluated, some different analysis groups evaluated over these different outcomes we will look at. It seems that the largest driver of this difference was with our no receipt of rescue therapy and then our NIHSS score change at less than 7 points. They also had looked at this outcome in patients who didn't have protocol violations, what they had deemed as protocol violations, and they had saw 68.8% of patients in the Andexanet group had hemostatic efficacy and 53.8% in the usual care group. This portion was statistically significant as it did not cross 1. Looking at our secondary outcomes, you saw the list of secondary outcomes that were intended to be reported. However, only a few were actually reported in the study body. So one of those being percent change in anti-factor Xa activity. And this was similarly looked at prior to, but now we are comparing it to our usual care group. And as expected, there was a statistically significant difference between the two groups, with Andexanet showing more decrease in anti-factor Xa activity. They also did report the MRS score of percent of patients with MRS of 0 to 3, and this is one of our functional outcomes that are typically seen in our stroke trials. It was reported at 30 days, however, and many of our other stroke trials have been reported at 90 days. However, this was not statistically significantly different between our two groups. So our patients with Andexanet, it was about 28% of patients and then 31% in our usual care group. Lastly, looking at our safety outcomes, this was thrombotic events and deaths at 30 days. It seems that our patients who received Andexanet had a higher number of thrombotic events, especially looking at our ischemic strokes. And this was statistically significantly different between the two groups. So overall, with the different outcomes, it seems that Andexanet has hemostatic efficacy, has better activity against our anti-factor Xa, so better activity in lowering that. However, it does seem to have higher rates of thrombotic events and no difference in our functional outcomes thus far. So what did the authors conclude about this? They concluded that the reduction in hematoma expansion with Andexanet as compared with usual care was accompanied by an increase in thrombotic events, including stroke. Determining the potential net benefit of Andexanet in acute intracerebral hemorrhage is challenging because the relative clinical effects are difficult to assess. Now remember, this trial was stopped early. So we said that 900 patients were initially supposed to be evaluated. However, you can see with these different outcomes, about half of that was evaluated, with more in our safety and then less in our efficacy endpoints. So some study critiques here. Looking at the trial design, there were a number of protocol amendments that occurred throughout the timeframe of the study. Some were to make the groups more homogeneous, less heterogeneous. Some of these protocol changes included controlling for blood pressure, time to reversal administration, and then including only intracerebral hemorrhages, not your subarachnoid or your subdural hemorrhages. And these seem to be reasonable protocol changes. Others were to increase the population size, and they also had some statistical analyses changes throughout the course, increasing the p-value from 0.001 at the interim analysis to try to stop the trial early to 0.031. And if you remember, our primary outcome had a p-value of 0.003. Looking at the comparator groups, they seem to be well-balanced and representative of our real-world patients. However, the comparator group itself seemed to be heterogeneous, so only about 85% of the usual care group received a PCC product, and it doesn't define what the other 15% of these patients received. Only about 61% of the patients who did receive a PCC product was the exact product known. However, of those 61%, mostly patients received a 4-factor PCC product. The median dose that was mentioned in the usual care group of those that did receive a PCC product was about 30,000 units. However, it's not listed whether many patients received a fixed dose, whether they received a weight-based dose. And as we know, there are multiple dosing strategies. This would have been nice to have a differentiation because we had that for the Andexanet patients, how many received the low dose versus the high dose. Looking specifically at the patient population, it seems, as I said before, well-balanced and representative of real-world patients, especially patients I would see here at the Detroit Medical Center. However, when looking at the severity of disease, many patients had a high GCS score, so the median was about 15, and a low NIHSS score, so about 9 between the two groups. So unclear if patients with more severe bleeds would benefit or see this difference between our two interventions. Again, looking at the interventions, the usual care group, as we had mentioned earlier, seems to be fairly heterogeneous, really unclear what we are comparing Andexanet to. Looking at the time to reversal, there was an initial part of the protocol where providers were allowed to, or pharmacists were allowed to mix up the Andexanet prior to knowing if the patient had a bleed or not. And as we know, this could affect the time to reversal. And if this same was not allowed in the usual care group, then this could create a difference. And we are not necessarily comparing our apples to our apples here, if that's the case. Also, as we know in the real world, this is not feasible due to cost as well as waste of the drug. This was later changed in a protocol amendment, but unknown how many listed in the different study groups that were evaluated did have the ability to mix this up prior to knowing if the patient had a bleed. Looking at endpoints. Many of the pre-specified secondary endpoints were not reported. There were some extras reported in the supplementary appendix to the trial. However, many were either removed in the different protocol amendments or to be reported in future studies. The functional outcomes were mentioned. However, as I said earlier, many of our stroke trials list the differences in MRS at 90 days, not at 30 days. So maybe evaluated earlier than we would have liked to see. And they did evaluate the different safety events and did report that Andexanet did have higher rates of thromboembolism. And this was evaluated in all patients who received any of the study drug, which I do think is a pro for the study. Important to note that these different drugs are safe. Looking at the analysis, one of the different protocol amendments that occurred changed the analysis of the primary outcome to this CMH or Cochrane-Mantle-Hansel test. This is not a new test that is out. It does compare two outcomes while adjusting for a third. So it seems to be reasonable, but why they had changed that partway through the study is unclear and raises some red flags. P-value was also changed at the interim analysis, as I had mentioned. Unclear why this would have been. And as you can tell, if they had gone with the initial p-value, we would not have stopped the trial early and the trial would likely be ongoing. And as I had mentioned earlier as well, some different populations were analyzed for the different primary, secondary, as well as our safety outcomes. And there are likely other critiques. However, we do have a limited time to talk about this trial today. So now what do we do with all of this data? There seem to be some lingering questions truly comparing the product to 4-factor PCC because our usual care group was so heterogeneous. So the question remains for health systems, what about formulary status? And will there be any further studies looking at these secondary outcomes as well as safety outcomes? Because the study was stopped early, it's currently, as reported, these are underpowered. However, if the study were to continue or if they were to report some additional data, could this change anyone's mind about adding Annexa to formulary if it is not already there? So our last audience participation question today, do the results of this trial sway your opinion on the debate Andexanet versus PCC? We have yes or no. Personally, for me, as I mentioned, we do not have Andexanet on formulary here at the DMC. And based on the results of this trial, it doesn't seem that we have a fair comparison of Andexanet versus 4-factor PCC. And I think with no difference in functional outcomes, me personally, I wouldn't jump to add this to formulary. It seems that we do have a difference in our hemostatic efficacy rates. However, what that means for our clinical outcomes has yet to be determined. So with that, I'd like to open it up for any questions, and thank you for listening today.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.